Welcome. In the previous session, we discussed malignant eyelid tumors in general as well as basal cell carcinoma and squamous cell carcinoma. In this session, we will be discussing sebaceous gland carcinoma, malignant melanoma, Kaposi sarcoma and Merkel cell carcinoma. Sebaceous gland carcinoma or SGC is a highly malignant and potentially lethal tumor. It arises from either meibomian gland in the tarsal plate, the glands of Zeiss in the eyelid margin, which are both modified sebaceous gland as well as sebaceous glands of caruncle, eyebrow or the facial skin. And SGC is the third most common malignant eyelid tumor, accounting for 1 to 5% of all periorbital tumors. Unlike basal cell carcinoma and squamous cell carcinoma, sebaceous gland carcinoma is not associated with solar exposure, and it affects all races. We had seen that basal cell carcinoma and squamous cell carcinoma as well as malignant melanoma tend to occur in patients with fair skin. And sebaceous gland carcinoma is twice as common in upper eyelid as in the lower eyelid. We had seen that basal cell carcinoma and squamous cell carcinoma have a predilection for the lower eyelid because the lower eyelid is said to be more exposed to sunlight. Sebaceous gland carcinoma is said to have a predilection for the upper eyelid because meibomian and Zeiss glands are more common in the upper eyelid, and sebaceous gland carcinoma is more common in women. Sebaceous gland carcinoma tends to occur in patients beyond 50 years of age but can occur earlier in life, which is rare with basal cell carcinoma or squamous cell carcinoma unless there is a familial genetic predisposition. Sebaceous gland carcinoma is said to be a great masquerader because it can mimic chalazion, chronic blepharitis, chronic conjunctivitis, basal cell carcinoma or squamous cell carcinoma. And sebaceous gland carcinoma usually has a yellowish color because of the high lipid content in the neoplastic cells. Typically, two forms of sebaceous gland carcinoma are recognized clinically. One is the plaque-like thickening of the tarsal plate from tumor arising in the meibomian gland. The other is the nodular type, in which we see a firm nodule resembling chalazion. So any recurrent chalazion should raise suspicion and should be biopsied. Whether plaque-like or nodular, sebaceous gland carcinoma typically causes effacement of the meibomian gland orifices and destruction of hair follicles with loss of eyelashes, called madarosis. Here we see a very localized area of madarosis in a patient with sebaceous gland carcinoma. Sebaceous gland carcinoma tends to spread intraepidermally, called pagetoid spread, which is a characteristic of sebaceous gland carcinoma. And this pagetoid spread may involve palpebral conjunctiva, bulbar conjunctiva and the corneal epithelium, and appears as a fine papillary elevation. Pagetoid spread can also be associated with marked conjunctival hyperemia and inflammation. So any chronic unilateral blepharitis or conjunctivitis should raise suspicion of a sebaceous gland carcinoma with pagetoid spread. Sebaceous gland tumors can be multicentric, occurring at two or more sites in the same eye, and may involve both the upper and the lower eyelid simultaneously. It usually metastasizes by the lymphatic route before spreading hematogenously or invading the orbit directly. Sebaceous gland carcinoma can occur as a manifestation of Muir-Torre syndrome, in which there is multiple tumors of sebaceous gland origin as well as keratoacanthoma, and which we have discussed in a previous session. Suspicion of sebaceous gland carcinoma demands a full thickness eyelid wedge biopsy. Shaved biopsies may miss the underlying tumor and reveal only inflammation and should not be done. Due to its multicentric and pagetoid spread, multiple biopsies are recommended from adjacent portions of the other eyelid and palpebral and bulbar conjunctiva, and fresh tissue needs to be sent to the pathology laboratory for special lipid stains. Sentinel lymph node biopsy is indicated for recurrent lesions, lesions involving more than 10 mm of eyelid margin, and for orbital invasion. Sentinel lymph node is the first lymph node in the drainage pathway from the lesion location. Excluding basal cell carcinoma, which is known to be predominantly locally destructive rather than having metastatic potential, sentinel lymph node biopsy is required for all other eyelid tumors. Because these eyelid malignancies tend to metastasize to lymph nodes before distant spread to other sites. On histopathological examination, sebaceous gland carcinoma show highly pleomorphic cells in lobules, and these cells have hyperchromatic nuclei and a vacuolated cytoplasm as we see here. Destruction of tarsus and adnexal tissue can also be found, and pagetoid spread in conjunctival or skin epithelium can be seen occurring distant from the visible tumor site, resembling squamous cell carcinoma. However, unlike squamous cell carcinoma, lobular arrangement is more prominent in sebaceous gland carcinoma, and the cytoplasm is more basophilic as we see here as compared to squamous cell carcinoma, where cytoplasm of the tumor cells are more eosinophilic. Special lipid stains such as Eyelid O on fresh tissue stains the lipid within the cytoplasmic vacuoles. 4 histopathologic types of sebaceous gland carcinoma have been described, and on immunohistochemistry, sebaceous gland carcinomas are positive for epithelial membrane antigen, adipohyalin and androgen receptors, but are negative for BER-EP4. Sebaceous gland carcinoma demands wide local excision by Mohs micrographic technique, and it demands extra care because of skip areas, pagetoid spread and multicentric origin of the tumor. Mohs micrographic technique is less successful in preventing recurrence in sebaceous gland carcinoma than it is in basal cell carcinoma or squamous cell carcinoma, and cryotherapy is an option for conjunctival pagetoid spread. However, sebaceous gland carcinoma is known to be relatively resistant to radiotherapy. Orbital exenteration is recommended for invasion of the tumor through the orbital septum, and regional lymphadenectomy with parotidectomy with adjuvant radiotherapy and chemotherapy are required for lymph node metastasis and distant metastasis. Sebaceous gland carcinoma has a 33% local recurrence rate, and 1/4 of the tumors have distant metastasis. Overall 5-year survival rate with appropriate treatment is 75%, and poor prognostic factors include primary tumor size more than 10 mm, involvement of both upper and lower eyelids, poor differentiation on histopathological examination, and evidence of lymphovascular invasion. Malignant melanoma is an invasive proliferation of malignant intraepidermal melanocytes, and it is the 4th most common malignant eyelid tumor, constituting 1 to 2% of all eyelid malignancies. It can arise de novo without a pre-existing lesion, but this is rare in the eyelid, and most malignant melanoma of the eyelid arise from pre-existing lesions such as lentigo maligna as seen in this picture, congenital melanocytic nevi as seen in this picture, or dysplastic nevi. Risk factors for malignant melanoma include sunlight exposure and fair skin, as with squamous cell carcinoma and basal cell carcinoma. Predisposing lesions, as we have just mentioned, can also give rise to malignant melanoma. Exposure to environmental mutagens can also be a causative factor, and genetic predisposition such as in dysplastic nevus syndrome, also called BK mole syndrome, can also give rise to malignant melanoma. The term BK arises from the names of the first 2 patients in whom this syndrome was identified, and BK mole syndrome is an autosomal dominant condition with more than 5 but typically 50 or more atypical nevi, and these atypical nevi have fried egg appearance with a central papillar darker area surrounded by a lighter macular area. Clinical features of malignant melanoma include variable pigmentation as seen in this picture, also irregular borders, ulceration and bleeding of the lesion, and an initial horizontal non-invasive intraepidermal growth phase followed by a vertical invasive growth phase through the basement membrane of the epidermis into the dermis. And the mnemonic A, B, C, D and E helps us to pick up malignant melanoma lesions early on, with A representing asymmetry of the lesion, B representing irregular borders of the lesion, C representing varying colors of the lesion, D for diameter of the lesion, which is usually larger, and E for an evolving lesion which changes in color, shape, size and thickness. The predominant majority of eyelid melanomas are lentigo maligna melanoma, and LMM develops in a lentigo maligna lesion, with 2.5% of lentigo maligna lesions giving rise to lentigo maligna melanoma. In a lentigo-malignant lesion, which is typically a flat pigmented macule, the malignant melanoma phase is represented by nodular growth. And in LMM, eyelids are usually involved from a lesion in the malar region, and the pigmentation can spread over the eyelid margin to the conjunctival surface. Less common melanoma variants occurring in the eyelid are the nodular melanoma and the superficial spreading melanoma. In nodular melanoma, the vertical nodular growth phase is the initial phase of the lesion, and there is no initial horizontal non-invasive phase as in lentigo maligna. So nodular melanoma is likely to have deep invasion by the time of the diagnosis, and nodular melanoma demonstrates rapid growth with ulceration and bleeding. Nodular melanoma may be amelanotic as seen in this picture. In superficial spreading melanoma, the melanoma starts as a small, slightly elevated pigmented lesion with irregular borders, which rapidly progresses to the vertical nodular growth phase as seen in this picture. The major prognostic indicator for melanoma is the depth of the tumor involvement, and this depth can be assessed either by the thickness of the tumor as in the Breslau system or by the deepest layer of the skin involved by the tumor as in the Clark system. In the Breslau system, if the thickness of the tumor is less than 0.75%, the 5-year survival rate of the patient is 98%, with lentigo-malignant melanoma having the best prognosis and the nodular melanoma having the worst. If the thickness of the tumor is more than 4 mm, the 5-year survival rate is less than 50%. And in the Clark system, the tumor is said to be in level 1 if it is limited to the epidermis, in level 2 if it reaches up to the papillary dermis, in level 3 if it reaches up to the interface between the papillary and the reticular dermis, in level 4 if it reaches up to the reticular dermis, and level 5 if it invades the subcutaneous tissue. Lentigo-malignant melanoma in level 1 and 2 have 5-year survival rates of 100%, and melanoma of any type in level 5 have only 15% 5-year survival rate. And melanoma involving eyelid margins are said to have a poorer prognosis than those which do not. Malignant melanoma demands a wide excisional biopsy, and a punch biopsy helps in depth estimation, which is so very important in prognostication. A sentinel lymph node biopsy is indicated if the thickness is greater than 1 mm, there is microscopic evidence of lymphovascular involvement, more than one mitotic figure is seen per high power field of the histopathologic section, or there is histopathologic evidence of ulceration of the tumor. A complete systemic metastatic workup is indicated if the thickness of the tumor is greater than 1.5 mm. On histopathological examination, lentigo-malignant melanoma shows dermal invasion of intraepidermal atypical melanocytes of lentigo maligna. As we have seen in a previous session, lentigo maligna is characterized by presence of atypical melanocytes in the epidermis all throughout the clinical lesion. And in the area where the lentigo maligna transforms into LMM, we find dermal invasion of the atypical melanocytes from the epidermis. In the superficial spreading type, we find atypical melanocytes spreading throughout the epidermis in a pagetoid fashion, and these cells occur either singly or in clusters. In nodular melanoma, dermal invasion is invariably present with large anaplastic epithelioid cells. On immunohistochemistry, malignant melanoma is positive for S100 and HMB45, HMB standing for human melanoma black. Malignant melanoma is usually removed during excisional biopsy with histologic control of margins, and a margin of 10 mm of normal appearing skin is taken when possible, as compared to a margin of 1 to 2 mm for squamous cell carcinoma or basal cell carcinoma. Cryotherapy is not indicated in cutaneous melanoma, unlike conjunctival melanoma, where cryotherapy is a treatment option. Treatment options for unresectable tumors or tumors with distant involvement include oncolytic virus therapy with TVEC, which is a modified herpes simplex virus which stimulates the immune system to kill the tumor cells, and TVEC is injected locally into the tumor or the involved lymph nodes. Immune checkpoint inhibitors are another treatment option for malignant melanoma, and immune checkpoint inhibitors inhibit immune checkpoints. Immune checkpoints are molecules on the surface of the immune cells which prevent activation of the immune cells. Cytokines such as interleukin-2, PEG interferon alpha 2b, and TNF-alpha have also been found to be effective in advanced stages of malignant melanoma. Signal transduction inhibitors have also been found to be effective in the treatment of malignant melanoma. And signal transduction inhibitors inhibit molecular signals such as BRAF and MEK, which promote cellular replication. Kaposi sarcoma is caused by human herpes virus 8, and it occurs in immunocompromised patients and elderly individuals. And Kaposi sarcoma is known to spontaneously regress following immune reconstitution in AIDS patients with anti-HIV treatment. Kaposi sarcoma presents as a reddish dermal lesion, and on histopathology, Kaposi sarcoma shows spindle cells mixed with vascular structures. Treatment options for Kaposi sarcoma are excision, cryotherapy, radiation, and intralesional chemotherapy. Merkel cells are touch receptors of the skin, and Merkel cell carcinoma is considered to be a neuroendocrine tumor. Merkel cell carcinoma appears as a painless erythematous nodule as seen here in this picture with overlying telangiectasis. It is known to be a very aggressive tumor with a high rate of local recurrence and distal metastasis. And following Merkel cell carcinoma, overall 5-year survival rate is less than 50%. On histopathology, Merkel cell carcinoma appears as a small round cell tumor which is immunohistochemically positive for cytokeratin 20 but negative for S100. Merkel cell carcinoma should be treated by wide surgical excision followed by chemotherapy and radiotherapy. Thank you for listening.